Respected chairpersons and discussants, learned audience, I am Dr. Amin, currently working as registrar at National Institute. My case is my worst nightmare in large STEMI. My patient, 65 years old male, smoker and hypertensive, however he is non-diabetic, presented with typical chest pain for 2 hours along with shortness of breath as well as orthopnea. He was a known case of chronic coronary syndrome with poor drug compliance. At the emergency department, we found his tachycardic, his blood pressure was high, and he had features of failure, and he had resting hypoxemia. So this is his ECG. You can see there is ST elevation in the anterior lead, and there seems to be some ST elevation in the AVR. So as the patients came within time frame, that is within 2 hours, so we planned for the primary PCI. So from this picture of the left side, you can see the right coronary is diseased at proximally somewhat, and it is also distally diseased. At the right panel, you can see the left anterior descending artery is getting collateral fillings from the right side. So this is his left side. As the patient was an anterior MI, you can see we directly went to the guide catheter, 6 French extra backup guide catheter. You can see after the first shot, his left main is totally occluded. The situation was very grave. So we were actually thinking, what can we do? Should we go for continue the primary PCI, or we will go for the CVG? You know, it's difficult to arrange CVG instantly, and patient is in failures, and considering all these issues, we proceeded to primary PCI. So at the left panel, at the next picture, you can see as soon as we advance the wire, the heart is moving sluggishly and blood pressure was dropping, and the soon patient went into arrest. So we started chest compression and started temporary pacemaker, intubated the patients. And the meanwhile, we are also trying to negotiate the wire. Unfortunately, we could cross the wire across the lesions, and our chest compression was ongoing. As soon as we could cross the lesion, we could see some flow was established, and then we instantly gave bolus dose of iptafibatide, and TME1 flow was achieved. So we and meanwhile his hemodynamics settled for a while. So we decided to pre-balloon, and we pre-dilated the lesion with a 2 into 15 millimeter compliant balloon. Then we deployed a stent, 3 into 38 millimeter, from left main ostium to LED mid. You can see some under expansion at the mid part of the stent. And TME flow doesn't seem to be TME flow 3. So we decided to post balloon, and we distally inflated at 3.5 into 15 millimeter at low pressure, that is 12 to 14, and proximally we inflated at higher pressure at 20 atmospheric pressure. And you can see the final legend, and TME 3 flow is achieved. And these are the hardware we used. And you can see the ECG, there is resolution of the ST segment elevations, and patient improved hemodynamically, and patient improved from cardiac arrest as well. So these are the messages that actually STMI can happen with total left main occlusions. Even it can be managed with primary PCI. And you know, in primary PCI, particularly in STMI of anterior extensive anterior cardiac arrest or heart failure, is a common feature. So we have to tackle, we have to be ready to face all these complications. However, in these settings, I missed, I was actually expecting if there was any ECMO or Impella or some circulatory support, probably my procedure could have been somewhat easy, and thrombosuction could also be a choice, but all these facilities are unfortunately not available in my cath. However, we could tackle these patients, and patients improved, and we could discharge the patients in a stable hemodynamic condition. Thank you for your patient sharing.